My name is Dr. Peter Gersten. My co-author is Dr. Christina Gersten, and I will be reviewing the chapter entitled Radiosurgery for Malignant Axial Spine Tumors. The issue of spinal metastases is increasing every year. Approximately 30 to 50% of cancer patients will have spinal metastases, period. Earlier detection and overall improved disease control has resulted in 60% of cancer patients surviving greater than 5 years. There are approximately 180,000 new cases each year in the United States of spinal metastases. The impact of spinal metastases on patients include the following: disabling pain, a loss of mobility, bony fractures and instability, and occasionally paralysis due to spinal cord compression. There are several surgical indications for spine tumors, namely pain, neurologic symptoms, and instability. The goal of surgical intervention is to minimize the effects of the tumor and maximize patient function and quality of life. There is a dual requirement of effective spine tumor treatment. Those are pain palliation or pain prevention and tumor control and prevention of neurological compromise. In 2005, the PATCHEL trial was published in Lancet and really changed everything regarding the management of these patients. It provided for Class 1 evidence to support the initial treatment of spinal cord compression with open surgery, and patients began to be referred to surgeons again for surgical intervention. We have the ability to perform these major surgeries, but with a price. Here you see a patient with a metastatic papillary thyroid carcinoma who underwent a significant open surgical intervention. We knew in the early 1990s that we could perform these major operations on these patients. But a decade later, we discovered that the surgical morbidity associated with these operations was significant. What are the adverse outcomes of conventional external beam radiation therapy? We think as surgeons frequently as that conventional radiotherapy is relatively safe. However, conventional radiotherapy is not always safe for all patients. This was a study that showed that of almost 300 cases of uncomplicated spinal metastases, meaning that they had not had prior surgery, nor radiotherapy, nor cord compression, there was a cumulative incidence of significant or serious adverse events, SAEs, was 24% at 180 days. SAEs increased with spinal instability and single fraction therapy. So what is spine radiosurgery? It is, by definition, the delivery of high-dose per fraction radiation, usually on the order of 14 to 24 gray in a single fraction, or hypofractionated radiosurgery of 6 gray in 5 fractions or 9 gray in 3 fractions. Another way of thinking of this is delivering radiation that is cytotoxic or ablative tumor dose sparing of normal tissue tolerance. The principal applications to the spine for spine radiosurgery are the following: as a primary treatment for resistant tumors, as reirradiation following failed conventional external beam radiotherapy, as a postoperative adjuvant, and as neoadjuvant therapy for primary tumors. In the early 1990s, with the advent of frame-based LINAC radiosurgery for intracranial disease, there were several researchers, including Dr. Alan Hamilton, a neurosurgeon, who performed frame-based spine radiosurgery. This article was published in 1995. What we knew was, in order to have a feasible and practical form of external beam extracranial radiosurgery, we had to move from frame-based radiosurgery to frameless image-guided radiosurgery. What are the requirements for spine radiosurgery? They include an accurate identification of target and surrounding normal tissues, sophisticated treatment planning for sharp dose gradients, reliable near-rigid immobilization, image-guided verification, and sub-millimeter accuracy of the radiation delivery. Why was spine radiosurgery one of the first extracranial targets for radiosurgery? There are important technical reasons. There is little motion of the spine with respiration when a patient is lying in a supine position. This allowed for frame-based radiosurgery initially, although that moved to frameless radiosurgery, and we can use bony radiographic image guidance. There are more practical reasons for why spine radiosurgery was the first area outside of the skull for extracranial radiosurgery. Prior to the advent of radiosurgery, we were unable to deliver conformal tumoricidal doses to spinal lesions. Radiosurgery filled a vacuum that we knew was present as neurosurgeons. Radiation oncologists and neurosurgeons were already working together side by side, performing intracranial radiosurgery. We have borrowed heavily from our experience with intracranial radiosurgery, but we have altered the techniques to the unique conditions of spine tumors. What are the indications of spine radiosurgery today? Well, it is an evolution in progress. We use radiosurgery as a primary treatment modality for medically inoperable patients in previously irradiated sites, as an adjunct to surgery, and for lesions not amenable to open surgery. What does the current evidence support? Conventional radiotherapy has been shown in several randomized trials with high quality evidence, as well as prospective studies with moderate quality evidence that it is safe and effective to treat metastatic spine disease. However, while there is a good palliation of pain, this is frequently short-lived. For stereotactic radiosurgery, there have been greater than 90 single institution reports, and now there is the RTOG trial showing the options and indications for radiosurgery. Independent of technology used, the reported outcomes are remarkably consistent. 85 to 100% of reported patients in these series have experienced effective palliation of pain. Pain is the primary outcome and indication for spine radiosurgery. Currently, 75 to 92% of patients have been documented to experience improvement of progressive neurologic symptoms in these studies. A systematic review of radiosurgery performed several years ago, or published several years ago, revealed 14 full-text articles that were reviewed, and the local control rate was 90% at 1 year. There was an early recognition of pain improvement when using radiosurgery. An article dating back to 2005 was one of the first publications specifically looking at pain control and quality of life after spine radiosurgery. In 53 patients in 1 year, radiosurgery was found to have a significant and durable pain relief in this cohort, and a recurrence in a subset of patients only after 18 months. For radioresistant tumors such as renal cell carcinoma, early studies also showed a significant improvement in pain, with a median dose of only 15 gray in a single fraction. A median time to pain relief was less than 1 month. There were no grade 3 or grade 4 toxicities, and radiosurgery for renal cell carcinoma was found to have a fast and durable pain relief. Looking at these patients more closely from the Cleveland Clinic experience revealed once again a rapid and remarkable long-term pain improvement even when adjusted for analgesic pain medication. A large-scale clinical evaluation of radiosurgery from 8 institutions in North America and Europe revealed a local control rate at 2 years of 84%. There were no high-grade toxicities, and the development of compression fractures was only 4% in this cohort. Looking more closely at this cohort, 82% of patients once again had significant pain prior to radiosurgery, and those improved. What radiosurgery resulted with pain improvement that occurred sooner and lasts longer compared to conventional external beam radiotherapy. A large-scale evaluation of patients who had had prior fractionated radiotherapy and then subsequently underwent radiosurgery also found a significant pain improvement following radiosurgery that was durable. What are the current recommendations for spine radiosurgery? Radiosurgery is safe and effective with durable symptomatic response and local control for even radioresistant histologies, regardless of prior fractionated radiotherapy. Radiosurgery should be considered over conventional fractionated radiotherapy for the treatment of solid spine tumor metastases in the setting of oligometastatic disease and or radioresistant histology. One study from the Sloan Kettering group found a 5-year outcomes after spine radiosurgery to be very favorable for these patients. Even when 58% of the patients had radioresistant tumors, they found a significant pain improvement that was durable. Only 14% of these patients required cement augmentation for symptomatic compression fractures. This number is decreasing with time as practitioners are using cement augmentation prior to radiosurgery. Radiosurgery has also been shown once again to be effective after conventional radiotherapy. From one multinational group from North America and Europe showed that the rate of compression fractures was only 4%, and the local 12-month control was 83%. %90 of patients had pain prior to radiosurgery in this cohort, and 74% had a clinical improvement in pain only 40% of, or 46% of patients reported any pain at last follow-up. When radiosurgery is combined with systemic therapy, the results are even more favorable. In this study, greater than 90% of patients had pain prior to treatment. At 12 months, when combined with systemic therapy, the cumulative incidence of local failure was only 4%. Can pain outcomes be improved with combination of new tyrosine kinase inhibitors and other systemic therapies? The results are very favorable for this. Today, radiosurgery can be incorporated into the multimodality treatment of patients with particular histologies. For instance, melanoma patients that are receiving systemic benefit from immunotherapy can also achieve significant benefit from stereotactic radiosurgery. The Radiation Therapy Oncology Group trial, RTOG 0631, has been published. This was the phase 2, phase 3 trial that demonstrated the feasibility of using these doses. There is always a question regarding single versus multiple fraction spine radiosurgery. In a study that we performed at our institution and compared to a second institution, pain control was significantly better in the single session group for all measured time points. The rates of toxicity and neurologic deficit improvement were not statistically different. Another review study that we published revealed that there was no clear advantage of 1 versus 3 or 5 fractions currently for spine radiosurgery. As long as there is a significant and sufficient dose to the tumor, the outcomes are equal. The adoption of spine radiosurgery is similar to that for intracranial radiosurgery. It parallels the way in which radiosurgery has been incorporated into the multimodality approach to intracranial lesions. Spine radiosurgery can avoid open surgery in many cases. It can alter the actual surgery performed so that we can perform a more minimally invasive surgical intervention. We can integrate radiosurgery into the systemic therapy of these patients, and we can use radiosurgery as a boost after conventional fractionated radiotherapy for bulky or radioresistant tumors. However, there are certain issues unique to the spine, namely the issues of spinal instability, and we frequently combine radiosurgery with percutaneous fracture stabilization using methylmethacrylate. This is an example from our series of a patient who had prior fractionated radiotherapy for a renal cell carcinoma metastasis to the lower thoracic spine. The patient's pain unfortunately returned after conventional radiotherapy. We treated this patient, as can be seen here, with 18.5 gray to the GTV in a single fraction. The maximum dose to the spinal cord was only 10 gray, and the patient achieved significant and sustained pain improvement following this treatment. For lumbar lesions at the level of the cauda equina pose a different issue. This is a woman who underwent fractionated radiotherapy for breast metastases to the lumbar spine. She returned with significant back pain. It was uncertain if this pain is related to compression fractures related to the prior radiation or if there is tumor present. So we perform a percutaneous cement augmentation procedure and place methyl methacrylate period. At the same time, we perform a biopsy. In this case, the biopsy was positive, and so we proceeded 1 week later with radiosurgery, a GTV of 16 gray in a single fraction. And what we know today is that dose is sufficient for a sustained achievement of local control as well as pain improvement. We can combine percutaneous fracture reduction and fixation with these patients. This allows for patients with painful pathologic compression fractures who require both a stabilization procedure as well as a radiation to be treated. We can at the same time achieve mechanical pain control with the cement and tumor control with the radiosurgery. By combining fracture fixation followed by radiosurgery, this allows for these two goals to be met. Our series published, as well as other publications, have shown that combining radiosurgery with percutaneous fracture reduction and fixation is very successful as a treatment paradigm that controls for both mechanical pain as well as local tumor growth. This is a case example of a 70-year-old woman with metastatic renal cell carcinoma and significant mechanical pain. This patient can be successfully treated first with percutaneous cement augmentation procedure, as you can see here, and then followed with radiosurgery, in this case 22 gray in a single fraction. The treatment time is less than 15 minutes, and 6 years later, she is symptom-free and even able to play golf. Therefore, radiosurgery is really changing the paradigm of treating patients with spinal tumors. The goal of all of these interventions is to avoid further surgery. This is an example of a woman with a recurrent chordoma. She had surgery, as can be seen here, at T1 with a corpectomy and spinal implants. When the tumor recurred outside of the prior radiation field, she was treated with 26 gray in 3 fractions. There has been a lot of discussion regarding an assessment of the responses to radiosurgery. This is a publication from the Spine Response Assessment in Neuro-Oncology, or SPINO group. This was put together to determine an international consensus for SBRT planning, image-based local tumor response, pain response, and imaging follow-up frequency. These tables demonstrate the recommendations from the SPINO group. These are guidelines for the assessment of response to spine SBRT. Many patients who require spine radiosurgery have previously undergone open surgical decompression and instrumented fusions. The instrumentation can cause issues with target volume delineation. In these patients, myelography, as is shown here, can be very helpful to determine the precise location of the spinal cord and neural elements, as well as to better delineate the vertebral body and tumor. We have also employed PET-CT imaging for contouring of the GTV. As can be seen in this case example, the contouring of the avid portion of the tumor is very easy, as you can see here, where we do not target the entire vertebral body, but just the tumor. This is a further demonstration of the same case where we can place a greater volume on the avid portion of the tumor and increase the dose to that portion. And for the less avid portion of the tumor within the vertebral body, we can create a PTV providing less dose, but still a clinically significant dose to the tumor. There are patterns of progression of the epidural tumor after postoperative spine radiosurgery. This has implications for target volume delineation, as was demonstrated in this manuscript. Therefore, we try to include the pedicles when contouring the vertebral body tumor in order to prevent such epidural progression. In this study, the authors attempted to create a prognostic index for spine metastases in order to stratify the survival in patients who were treated with spine radiosurgery. They found 4 different groups that had either an excellent prognosis, a fair or good prognosis, and a poor prognosis. Such an index will help us determine which patients would best be served by undergoing spine radiosurgery. We have a good understanding of which patients can safely be treated with radiosurgery and which patients cannot. For patients with a Bilski score of 0, 1A, 1B, or 1C, can all be easily and safely treated with radiosurgery. For patients with a Bilski score of 2 or 3, those patients frequently require an open decompression first, followed by radiosurgery. This concept has come to be known as separation surgery, where the surgeon separates the tumor from the spinal cord and neural elements and decompresses the neural elements, performs the necessary instrumentation for stabilization, but leaves the tumor alone at the time of surgery such that it can be treated at a later date with radiosurgery. And this allows for a more minimally invasive approach to these patients. This is translated into a minimal access spine surgery, or MAS, for decompression and stabilization, and several centers have published their experience with this concept. It minimizes the risk associated with open surgery, and now radiosurgery becomes part of the surgical approach to these patients. Is there evidence to support that combining surgery and radiosurgery is effective for these patients? Absolutely yes. There have been multiple studies now that show that patients who undergo radiosurgery after open surgery rather than conventional radiation therapy have a significantly better long-term outcome. Most importantly, we can avoid the effects and risk of treating these patients after open surgical instrumentation with fractionated radiotherapy. We know that fractionated radiotherapy is associated with wound healing issues and also includes the portion of the vertebral body that is where there is no tumor, but where we are trying to achieve an interface between the instrumentation and the bony elements. We believe, and several studies have supported this, that there is a higher rate of fusion when radiosurgery is used compared to conventional external beam radiotherapy, and a lower rate of hardware failure. There is also likely a less morbidity associated with wound healing issues in these patients. This leads to another issue that is unique to spine radiosurgery compared to intracranial radiosurgery, and that is the issue of spinal implants. A concern has been raised of the ability to safely and accurately perform spine radiosurgery in post-surgical cases in which there is titanium instrumentation, stainless steel instrumentation, or methylmethacrylate that have been implanted without using implanted fiducials for image guidance. However, with today's technology of cone beam CT imaging, we can safely perform radiosurgery on these patients, and multiple studies have supported this. In our practice, greater than 30% of our patients have some form of spinal implantation. I believe that a paradigm shift has been created when radiosurgery has been applied to the treatment of spine metastases. Spine radiosurgery has changed the way that we approach patients, specifically with oligometastatic disease, just like radiosurgery has done for intracranial disease in regards to brain metastasis. A decade ago, there was great debate that was similar between whole brain radiotherapy versus radiosurgery for brain metastases. Now, it is well accepted that radiosurgery has significant benefits to patients with brain metastases compared to whole brain radiotherapy. A significant amount of data is now supporting a similar conclusion for spine metastases in a certain subset of patients. In the future, perhaps we can talk about radiosurgical decompression. There is a consideration currently of the degree of spinal cord or spinal canal compromise for patients who require radiosurgery. As I stated earlier in this talk, several patients with severe spinal cord compression first require open surgical decompression before radiosurgery. However, there are cases in which patients cannot safely undergo open surgical decompression. This is a case example of a gentleman who underwent an open decompression infusion for a T10 lung metastases. Unfortunately, his tumor recurred after fractionated radiotherapy. He could not undergo any further open surgery because he was anticoagulation dependent. We therefore performed radiosurgery as a radiosurgical decompression. He was treated with 27 gray in 3 fractions, and within 3 months, using this ablative dose, there was a significant decompression in his spinal canal and neural elements from the tumor as a result of treating this area with high-dose radiosurgery. Today, we have a much better understanding than in the past about the spinal cord tolerance and complications associated with radiosurgery. We know that spine radiosurgery can be performed very safely. We try to keep the point dose to the spinal cord in a single fraction of 10 to 12 gray, believing that that is a safe dose for these patients. We have published our experience of the long-term outcomes after stereotactic spine radiosurgery for spine metastases and published graphs comparing a radiation dose response for late toxicity with 5 and 10-year rates in a series of 562 patients. We have determined that the number of grade 2, grade 3, and grade 4 toxicities are exceedingly low in this patient population. But we are always learning of ways to decrease these toxicities even further. This leads to the importance of multi-institutional and multinational collaboration. Multiple institutions have combined their experience and pooled their data to more effectively demonstrate the risks, benefits, and alternatives to spine radiosurgery. There is currently consensus regarding the proper way to contour tumors of the vertebral bodies when performing spine radiosurgery. We have a good understanding of what portion of the tumor should be contoured and what part of the vertebral body is at a low risk of recurrence and does not need to be contoured into the CTV. The important take-home message is that spine radiosurgery and intracranial radiosurgery are very different. There are important differences between spine and intracranial radiosurgery. There are different indications, there are different technologies, different outcomes, different limitations, and different organs at risk. In a similar fashion to the way that radiosurgery is today an essential part of the treatment paradigm for intracranial tumors, radiosurgery has become an essential tool in the multimodality treatment for spine tumors. We are really only at the tip of the iceberg of this exciting technology. Thank you very much for your attention.